I'm here with Dr. Linda Sheehan, who has opened this meeting for both us surgeons and anaesthetists. And I would just like to thank you for the really inspiring opening presentation you gave. You said some really interesting things, so ethics are kind of untrendy. But a couple of things I took away was that we're all moral agents, as you said, and it's really our obligation to understand a bit more about bioethics and help it, get it to help our clinical practice, and not can I, but should I. Can you extrapolate a bit on that? Because that really was the bottom line for me. In every interaction with a patient, I'm kind of going to, particularly complex, more frail patient, not can I or can we, but should we?
Yeah, I mean, I think, with the rise of medical technology and the expansion of the options of things that we can do in whatever patient population, what we're seeing more and more is not whether or not something is possible, but whether or not it should be done. And the should and the ought, that's really the space of ethics. That's the space of value judgments, expertise, consensus decision-making, iterative discussion to come out with some idea of what's the best thing to do here. Not just what is possible, but what's best. And really that's what we're trying to navigate. In terms of it being untrendy, yes, I think explicit ethics discussion and discourse is probably untrendy, but foundational for us from a medical practice perspective. So absolutely fundamental underpinnings. And the literature shows us that actually doctors know that. They understand ethics implicitly, but they're not quite so good necessarily when they need to be explicit.
And having the conversation.
And trying to kind of trade off values or prioritise things in an explicit way is kind of the skill that we need to re-engage with, I think.
Yeah.
So we already know all this stuff. It's just about operationalising in a way that fits for our clinical context, and really that's what we're trying to negotiate.
I wrote this down. So clinical ethics provides us a rigorous and defensible rationale, and I really like that. It's about less about me and my biases and opinions, but let's make it objective, and what is the rationale and how can I defend this decision so I can kind of portray it to my patients or the rest of my team and make a decision that's in the best interest of this patient.
Yeah, absolutely. So I mean, obviously best interests is a contested space, right? It's a ethics term, it's a loaded term. What is best might defensively be determined differently by different moral agents, but we have an obligation to decide together with other values like patients' goals and values, other clinicians' goals and values, to come to some sort of common ground around that. So absolutely, I think that sort of obligation to sort out what is best is really what we're trying to do. That's absolutely it.
Yeah, and you said something like, what is the best next step? So, for this patient, where are we going to go to from here? And I think sometimes we're so focused on, they've been booked for surgery, that's the next step because they've been booked, and trying to take a step back and go, hang on a second, perhaps the next or the best next step is to involve ICU or go and chat to the surgeon, then come back to the patient, not just follow when the momentum's kind of happen, just go with it.
This is the big thing, isn't it? We didn't get a chance to really unpack that much in the session, but this runaway train that we live in, this organisational culture and structure, that Swiss cheese model of how the heck they get onto the theatre table.
That's right, you feel like the horse is
actually
bolted.
Everybody around the table is going, I'm really not sure that this is the best thing to do.
Absolutely.
But they're already knife to skin and the machinery is already going. I mean, I guess taking it back a few steps, there's two things to talk about there. One is the procedural justice thing, that ethics of process thing, recognising that there are some core things that ought to be part of the journey to that patient being draped. And part of that is deciding what you think is best, recognising when you need to intervene, having consensus between experts about what's probably the best thing to do, but also then being prepared to say, I'm not going to throw foolishness after folly. Okay, we've got this far, but if we do that work now, even if the patient's draped and in the anaesthetic bay, then we're doing our due diligence. We're doing the moral agency piece. But letting the dominoes go past, it's not okay.
No.
We have a decision. We put the hand in or we let it go. That's part of the moral agency. And for us in medicine, that's a personal and a professional obligation. So we are accountable for the outcomes in that context, and that's part of taking responsibility for ourselves. And that's that rigorous bit, that rigorous and defensible rationale. We can't be certain we're right. We may make a different decision next time based on our experience and expertise. But we're engaging with the questions and we're doing our best to come with the best possible answers. That's as much as we can do.
Thank you so much. I hope it empowers, certainly empowered me, and I hope it empowers everyone in the audience to think about what should I be doing, not what can I do. So thank you so much.
Great. That
A
was the
privilege
goal.
to meet
Thank
you.
You too.
Thank
Thanks
you
a
so
lot.
much.